So now I invite our next speaker, Dr. Subashini. She's going to talk on CCT and corneal hysteresis. And I also request the next speaker to be ready on the other side, Dr. Sharini.
Respected chairpersons and the audience, a very good morning. So my topic is on CCT and corneal hysteresis. So CCT and corneal hysteresis are two important variables. They can be even considered as biomarkers in assessing the risk and progression in glaucoma. So if you see the cornea, it has the physical property such as the corneal thickness and the curvature, and the physical behavior or the biomechanical behavior, which is the corneal hysteresis. Assessment of central corneal thickness have now become an integral part of the diagnosis of glaucoma in today's times. And lower CCT is a known risk factor for glaucoma, we know from the oath study. For every 40 micron of corneal thinning, there's a twofold increase in the risk of developing glaucomatous optic neuropathy over a 5-year period. CCT can be measured using a simple handheld ultrasound pachymeter, and there are also other equipments which we have in the clinic, the optical biometer, the topographer, AIOC2024, which can measure the corneal thickness. Corneal hysteresis, what do we mean by corneal hysteresis? It actually reflects the ability of the corneal tissue to absorb and dissipate energy. So corneal hysteresis is akin to a shock absorber. The normal values range from 10.24 in some studies and 10.7 in others. And the most important thing is corneal hysteresis, it does not vary like IOP significantly throughout the day. So low corneal hysteresis means it has poor shock absorbing, the eye has poor shock absorbing capacity, which makes it susceptible to the damage because of the high IOP in terms of progression and predicting the risk. So the ocular response analyzer, ORA, is a very good instrument for measuring the corneal hysteresis. And it works on the non-contact technology, and where it uses applied force, and there is an electro-optical system which measures the applanation. So you have the right and left eye with the values of IOP-CC, CH, and IOP-G. So when the applied force, when the force is applied on the cornea, it causes applanation, the deformation. So that pressure applanation is called as applanation 1. The pressure at that point is P1. And then when the cornea returns back to its original position, the pressure reading at that time is the applanation pressure 2 or P2. The difference between this P1 and P2 gives the corneal hysteresis, and average of this P1 and P2 reading gives the IOP-G, and IOP-CC corneal compensator is where it takes into account all the corneal artifacts. So it has been shown that GAT and the ORA IOP-G show good agreement. So the other instrument used to measure the corneal hysteresis is the corneal Corvus-ST, as Dr. Shushma had told. It stands for corneal visualization Scheimpflug technology. This is also a non-contact technology. And actually the deformation and the geometric changes in the cornea are measured and using a high-speed Scheimpflug camera. And it gives a very detailed report, some 37 parameters with the latest version. It gives the biomechanical IOP, which is an important parameter. It doesn't actually give the corneal hysteresis value. And the deformation process is actually captured by this Corvus-ST. So actually low corneal hysteresis means diminished ability to dissipate energy in response to applied stress. Applied stress is the force, and the strain is the deformation that happens. So, and this makes it more susceptible to the glaucomatous damage. And low corneal hysteresis is seen in POAG, asymmetric POAG, PACG, NTG, PXF glaucoma, congenital glaucoma too. In a multivariable model, they have seen that corneal, it is corneal hysteresis and not CCT, which can discriminate between the POAG eyes and the normal group. CCT could be normal in both normal and POAG eyes, but corneal hysteresis is low in the POAG eyes. So corneal hysteresis can be considered a surrogate marker for glaucoma, a surrogate marker for ocular stiffness, for the lack of compliance and trab meshwork, the peripapillary sclera, and the lamina cribrosa. So in this study actually showed that low corneal hysteresis but not CCT was associated with progressive visual field loss. You can see in this diagram when the corneal hysteresis is less than 10 mm mercury, the predicted visual field index values show a downward trend over time. But whereas on the right side, when the corneal hysteresis is more than 10 mm, you can see it's all in the horizontally maintained or shows the upward trend. This is another paper by Susanna et al. And they actually showed that the cumulative probability of developing glaucoma is more when the CH is less than 10.2, the dark line. So it is a risk factor for predicting glaucoma. And in the same paper, the hazard ratio was calculated for various parameters. And for CH, it was seen it's 1.21 with significant p-value, whereas for CCT, it's only 1.15 and not significant. This is a population-based study where there are 96 UK biobank participants were there, and the corneal hysteresis was measured in all of these people, and they found that low corneal hysteresis was significantly associated with a higher prevalence of self-reported glaucoma when the CH was less than 10. And this is a paper correlating CH with CCT, and the correlation was found to be strongly positive in normal eyes, in normal eyes, and moderately positive in glaucomatous eyes. There are factors which affect the corneal hysteresis like CCT, age, diabetes, axial length, keratoconus, IOP. But then the fact of the matter is none of these parameters have been considered in any of the ORA studies. And medications also can affect the can confound the CH value. So, for example, prostaglandin analogs induce structural changes in the extracellular matrix, and this results in low CH and can confound the significant association between CH and glaucoma. So now, should there be a historic change in clinical practice? So though corneal hysteresis is the only factor, parameter that measures the biomechanical property of the eye, still, and there is evidence to show that it's a strong risk factor, and there is instruments to measure the corneal hysteresis. Still, it's not widely used in clinical practice. So this is a question I would like to ask the panel. So we need to consider CH equal or at least equal to CCT because they have a role in glaucoma management and risk stratification. Thank you.
Thank you very much. That was a comprehensive view of both hysteresis and corneal thickness.